morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. We have another Yuha's Neurosurgery Grand Rounds, and I'll just turn it over immediately to Yuha. Good day, Yuha. Unmute there, Yuha. Unmute, Yuha. Go ahead.
Okay, the first presentation is by Xubin because he has some other webinar later, so he will begin. So go ahead, Xubin.
Okay, thank you, Yuha. So today my topic is how to avoid delayed ischemia after bypass. So we can see how much blood flow can a high flow bypass supply. You can see the whole left hemisphere and the contralateral side ACA territory was all fed by this high flow bypass. It's a saphenous vein from ECA to saphenous vein to M2. So with this kind of technique, we can do anything. So to avoid the delayed ischemia of the bypass, the pre-operative plan is crucial. So we should guarantee enough blood flow replacement for parent artery of aneurysm. Intraoperative, make the temporal occlusion time as short as possible. Choose the right position of stoma, which means that delta P should be bigger. Keep the blood pressure at the baseline of preoperative or a little bit higher, around 10%. Use progressive clip. Post-operative management is also very important. The blood pressure should keep a little bit higher than the baseline. And for the moya-moya vasculopathy, we should give the extra fluid around 25 to 30%. So for the ICA aneurysm, we should make a tailored bypass plan. At first, we should estimate the natural collateral blood flow. We will use a balloon occlusion test. Normally, we use 30 minutes balloon occlusion test. If the neurological, there's no neurological deficit, so we will use enhanced balloon occlusion test, which means the blood pressure decreased 30%. If it's still negative, this kind of ICA can be sacrificed immediately. But if it's there's some symptoms, we will use STA to MCA double bypass combined ICA occlusion. If the patient couldn't tolerate the balloon occlusion test, we should make the plan of blood flow replacement. If the ICA only fed the MCA territory, the patient is a male, STA diameter larger than 1.2 millimeter. Normally, the double bypass is enough. If the patient is a female, we still need the radial artery. If the ICA not only fed the MCA territory, but also the ACA territory, definitely we would use the radial artery, combine the STA to MCA double bypass. If the MCA, if the ICA not only fed the same lateral hemisphere, but also the contralateral ACA territory. So this kind of condition, we will use saphenous vein, just like the first slides. So this is an example. This is the ICA proximal giant aneurysm. The patient suffered a sudden right hemiplegia for 3 months. So you can see this is a giant extracranial ICA aneurysm. The radiologist tried to put the fluid diverter into the aneurysm, but they failed. So the patient was introduced to me, and we did a BOT at first. There's very few collateral blood flow from ACOM and the PCOM. So I used the very fast anastomosing technique So this is a loop technique. The hand movement was even less, so it's very fast. So I did the double bypass for the patient. You can see the ICG. This is a intraoperative ICG. You can see the blood flow comes from the double STA was very well. And then I use a proximal progressive clip, which I clipped the ICA around 30% at first. Then in the next 6 days, I achieved total occlusion of the ICA. So after the total occlusion of the ICA, we redo the angiogram. We can see the double bypass was all patent and feeded the whole MCA territory. And then the ACA was also enlarged a little bit, and the PCAM was also enlarged. There's more collateral blood flow than the preoperative condition. So now the ICA can be totally sacrificed. For the MCA aneurysm, we also should guarantee enough flow replacement for M1 or M2 or M3. This is our strategy. It's already published 2 years ago in World Neurosurgery. In the MCA aneurysm, because of the perforators was very important of M1 segment. So normally we will use the MEP SCP monitoring. And the ICG flow 800 is helpful in selection of the recipient artery. So normally we will use the hybrid operating room. So you can see this is the intraoperative angiogram. You can see the double bypass of the STA already replaced the whole MCA territory. For the moya-moya vasculopathy, we found the two type of pressure gradient of MCA. This is the first type. It still keeps the physiological direction, which means the P proximal larger than P distal. This is the second pressure gradient of MCA, which is a reversed physiological direction, which means P proximal less than P distal. So we should make the bypass according to this different pressure gradient. So this is a red T sign, which means the bidirection of fast blood flow, which means a big difference of delta P. So this kind of condition, bypass is sustainable. So on the left, we can see this is a single bypass. Right side is a double bypass. So the red T was all very clear. But sometimes we will encounter one short arm of red T. So this is means the delta P is very positive. Actually, this is a borrowed case from Dr. Zhang, and you can see after 1 week, the bypass was almost occluded because the delta P was too small. So moya-moya, actually, this is we can see the bypass was enlarged. It's larger than 3 millimeter, and you can see it not only feeded the whole hemisphere, but also the contralateral frontal lobe. So this is what we can achieve, the vascular revascularization for moya-moya vasculopathy. And you can see almost all the whole hemisphere can be fed by ECA branches after the surgery. So this is a take-home message: how to avoid delayed ischemia after bypass. The preoperative plan every complex aneurysm should have a tailored plan for blood flow replacement and the protection of important perforators. Surgical plan should be as simple as possible. Intraoperative management, bypass time should be as fast as possible. Choose the right position of stoma. The delta P is very important, especially according to the analysis of the pressure gradient. Keep the blood pressure to the baseline as preoperative or a little bit higher, normally only 10%. And we can also use progressive clip, which can guarantee, which can prevent the delayed ischemia. If we have some ischemic symptoms, we can lose the clip and make the blood flow from the ICA a little bit higher to prevent the ischemic condition. So MEP and ACP monitoring is important, and intraoperative ICG or angiogram is helpful. Post-operative management is also very important. The blood pressure should keep stable. For the moyamoya patients, fluid expansion is also very important. So this is my personal experience in bypass. This is my recommended learning. This is a common fluid mechanic principles. This is a Poiseuille's law. We can see the picture where this is on the right side. We can see the in the vein a lot of different pressure, different blood flow velocity can show in this very short segment of vein. So the hemodynamic change after bypass is very complicated. And we should use this Poiseuille's law and Bernoulli's principle to understand this kind of change. This is the common fluid mechanic principles. This is Bernoulli's principle. It's mainly about the blood flow energy loss. So we can see this is ICA. Some blue lines, actually, this is the extra energy loss in the blood flow. Okay. So today is my presentation. Any questions?
Thank you, Subin. Are there any questions?
Yes, I have a question. When you say about the time in the how much fast the bypass needs to be done, so how many minutes? 20 minutes, something like that? There is a time in the one you need to make the bypass?
For me, normally it's less than 15 minutes. My mean occlusion, temporal occlusion time is around 13 minutes. But for the deep located bypass, it's I can control the temporal occlusion time less than 20 minutes.
Okay, thank you.
Something else?
Can I ask you one question?
Okay.
I'm Hideko Kimura.
Hi.
Nice to you.
Hi, Kimura.
So nice. Thank you. Excellent presentation. Yeah, I have one question for you. So if you find a small red T sign after the bypass placement, small incomplete red T sign, do you need to bypass suture to avoid the delayed occlusion? Do you need to additional suture bypass intraoperatively if you find
actually this is according to the preoperative analysis. because if you choose the the wrong position, if the delta P was very small, and that can create a short arm T at the bypass near the stoma. So this kind of condition is very difficult to treat.
Yeah.
But if you have this kind of condition, my recommendation is use another branch of STA.
Another branch of STA.
Yeah.
Yeah. I see. Thank you.
You're welcome.
I agree with you. Thank you. Thank you.